Today we'll be discussing dry versus moist wound healing. In this presentation, we'll be going through the history, the advantages, and the disadvantages of both.
Alright, so to start, we'll be talking about dry wound healing and its history. So, dry wound healing was still traditionally used up until the 1960s and was thought to protect the wound against secondary infection. This was achieved by applying dressings to absorb all exudate, creating a dehydrated wound. In addition to this, wounds were exposed to assist in drying of the wound. The eschar or scab was then formed and was thought to create a barrier against bacteria. Alright, so some dry wound healing advantages. So it can provide physical debridement when using dressings such as gauze. It can also be highly effective in highly infectious wounds. There's a lower cost for dressings, a decreased chance of maceration due to the decrease of moisture, and there's also a decreased chance of malodor. So some disadvantages of dry wound healing is dry wounds decrease supply of blood and nutrients, which results in a barrier to cell migration and slowing of epithelialization, which creates a reduced healing time. There's an increase in pain in dry wound healing. Infection can occur due to exposure to air. Dressing removal can be painful. There's lower healing times compared to moist wound healing. The eschar may fall off, creating re-injury and scarring. Change of dressing can create destruction of the wound, and there's an increase in dead tissue and fibrin.
We are now going to be talking about moist wound healing and discussing a brief history as well as advantages and disadvantages. So just to begin with the history. Hippocrates first noticed the fact that wounds healed much better if they were kept moist with poultice and covered with plenty of amounts of leaves. It was first thought that wound dressings were designed to absorb and remove any exudate to dry the wound out and allow for a hard dehydrated eschar to form in the belief that drier wounds would be less likely to become infected. This idea is known as dry wound healing. This was then challenged by many researchers as certain people came to the belief that Hippocrates was right all those years ago. Once they had done some research on the topic, that moist wounds would heal quicker than dry wounds through the development and migration of new skin that had covered the wound bed. It has now since been established that moist interactive healing is the gold standard for patients with adequate blood supply who can produce healthy granulation tissue, re-epithelialization, and mature healing.
Historically, a typical wound dressing had a strong emphasis on absorbing and removing exudate to create a dehydrated eschar. This was believed to create an environment for optimal wound healing while simultaneously reducing the risk of infection. However, moist wound healing is now unequivocally the frontrunner in terms of preferred environments, where a moist interactive healing is the gold standard for patients with adequate blood supply who can produce healthy granulation tissue, re-epithelialization, and mature healing. The theory behind the movement stemming from the early 1960s is believed and now known that promotes faster healing along all four stages of the process. Autolytic debridement requires a moisture-rich environment to allow the enzymatic destruction of selective tissue by rehydrating and softening the unwanted wound constituents, such as slough and necrotic tissue. Now, less pain in a moist wound is surrounded by the notion that the wound is covered by an occlusive dressing. This typically enables painless removal of dressings, focusing on not damaging newly formed tissues, stalling the healing process and exacerbating the inflammation. Additionally, the dressing itself has the potential to cool the nerve endings, reducing the conduction of pain. With a dry wound in mind, the medium itself is less conducive to the migration of cells and around the wound. This, as a direct consequence, results in the greater gradient needed for the direction of movement, adjunct with increased enzymatic production. A follow-on to this is a collagen matrix that is desiccated at the wound edge, affecting surrounding tissue. Healing will be delayed. In conjunction with increased migration, in comparison to the eschar and dry environment, the wound exudate associated with a moist wound is comprised of growth factors, microorganisms, red blood cells, and platelets. This in itself aids in increased fibroblast proliferation, collagen synthesis, and greater accumulation of nutrients such as keratinocytes or glucose to the site. This leads back to the general association of moist wounds and faster healing, as the combination results in angiogenesis and wound contracture earlier on in the piece. The microorganism aspect of the exudate may provide the wound with a pathological problem, which can be the case. However, our normal flora is normally consistent within it, being a biological barrier to help prevent infection. A moist wound is not always naturally occurring, hence the synthetic use of dressings to provide a happy medium is sometimes necessary and can come with its own benefits. The impact of infection is significantly less when using a moist wound dressing. Hydrocolloids are associated with the lowest incidence of clinical infection. Additionally, the use of microbial dressings whilst ensuring a moist setting reduces the risk of infection, which, as stated before, can stall the wound in its inflammatory stage, which is not good. Lastly, the analgesic characteristic of moist wound dressing is appealing, as reduced pain can promote healing and improve the general well-being of the patient in the healing process, which is good news. As you can see, there is a plethora of advantages of a moist wound bed, all with the holistic approach on improving wound healing capacity. So in layman terms, it's important to keep the wound moist, not too moist, but not too dry, but just right.
So even with all those advantages associated with moist wound healing, there are still some disadvantages, and I'll go through those ones now. So with moist wound healing, it becomes a breeding ground for infections if the dressing is poorly managed. It can be uncomfortable for the patient, and that's dependent on the dressing used and the location of the wound. It can produce a malodor. Maceration can occur if the wound is not monitored or the dressing is inappropriate for the wound itself. It's heavily reliant on patient compliance. Some wounds do require regular dressing changes, and if this isn't met, infection can result. Some dressings may cause skin irritation and contact dermatitis. Patients may be exposed to possible allergies as a result of the dressings used. It is a high cost as well to the patient due to the regular need to change the wound dressing, and is inducing an exudate phase.
Ideal environment for wound healing. Moist wound treatment provides for faster healing, autolytic debridement, fewer infections, and less pain in moist wounds compared with dry wounds. It substantially reduces the time needed for re-epithelialization and leads to decreased inflammation, necrosis, and scar formation. This type of treatment does not have any adverse effects on the wound or its surrounding tissue. It allows delivering antimicrobial agents, analgesics, cells, growth factors, and micrografts to the wound. The transplantation of cells or addition of growth factors makes it possible to create a regenerative wound microenvironment that promotes healing as opposed to excessive scar formation. Moist wound healing prevents dehydration and improves the process of angiogenesis and collagen synthesis, as well as increased breakdown of dead tissue and fibrin. Wound fluid for moist wound treatment stimulates fibroblast growth and keratinocyte proliferation.
So what's the debate? There is no debate. After assessing the high quality evidence provided, there is no doubt that moist wound healing is much more effective wound preparation for wound healing compared to dry. However, it is crucial that ongoing patient assessment, practitioner knowledge of the type of wound, types of dressings, experience and evidence is used when treating these wounds of patients. If this criteria is not met, treatment can be a waste of time, money, and can place patients at a high risk of poor outcomes. Thank you for listening.